Thank you very much for this invitation to talk to you all regarding hypotension in the neonate, which is sometimes a controversial topic. But the treatment is extremely important because babies who develop hypertension could be very sick, and the proper management is extremely important to improve their survival as well as reduce their disability. So, during the next 45 minutes, I'll be talking about the definitions used for hypotension, and we will discuss regarding the principles behind the decision when you are going to take that decision to treat hypotension, how you're going to assess a baby with hypotension, and how you are going to treat these babies in a rational manner. Right, next slide, please. Yeah. So, the hypertension in neonates, generally we have been taught that it is the normal blood pressure in newborns is the mean blood pressure is equal to the gestation in the corrected gestation or the appropriate gestation in a term baby at that particular time. However, this definition has been quite controversial because studies have shown that when you stick to that definition and if you start treating babies depending on that single number of blood pressure, we are going to overtreat a lot of babies unnecessarily. Next slide. Yeah. So therefore, the British Association of Perinatal Medicine from UK also defines hypotension as mean arterial blood pressure less than corrected gestation in weeks in a baby. However, they are talking about invasive blood pressures in this situation, something that we all need to keep in our mind because in our setup, it's usually the non-invasive blood pressure that we use. To check the invasive blood pressure, you always need to have the arterial line, either as a peripheral arch line or as a UAC line. And one other point that I need to emphasize at this point is even this definition could be an overestimate in extremely preterm newborns. Next slide. Yeah, next one. Yeah. So therefore, we have to classify hypotension into more useful way, which is clinically useful us because it tells us whether we need to manage these babies or not. So we divide these babies into moderate hypotension and severe hypotension. Moderate hypotension is when your invasively measured mean arterial blood pressure is not lower by more than 5 millimeters of mercury. So, for example, if you are managing a baby 30 weeks corrected gestation, your moderate hypertension range would be 25 to 30. Whereas severe hypertension is when your invasive mean arterial blood pressure is lower than more than by 5 millimeters of mercury. So if you take the same 30 weeker, if the baby's blood pressure lies between 20 to 25, then you call it severe hypertension. We should not confuse the concept of poor perfusion with hypotension. These are two separate entities. Perfusion of baby depends on a lot of other factors. You have to take into consideration the heart rate, especially the capillary refilling time, urine output, saturation, and a lot of other parameters. So one should not confuse between poor perfusion in a newborn baby with hypotension. These are two specific entities. Next slide. So we are now going to look at some important causes of hypotension in newborn babies, whether they are preterm or term. Commonly, We see some babies developing vasodilation, therefore reduction in the peripheral vascular resistance. This we see mainly in babies with sepsis, especially septic shock, or babies with necrotizing enterocolitis. In some babies, they can be hypovolemic as well. Especially we see this condition in term babies who have lost some blood during delivery, especially following placental abruption, or who has had umbilical cord accidents, or somebody who has bled due to subgaleal hemorrhage, or in a preterm baby who has had significant amount of insensible water loss. And sometimes we know those who are having some kidney problems or having some metabolic issues could have polyuria, especially when they are having high sugar levels. This can also lead to hypovolemia in these infants. Diastolic dysfunction is also common in these babies. Common example would be tension pneumothorax, cardiac tamponade. We also see babies with poor contractility. And also, occasionally, they can develop arrhythmias where they develop hypotension, but commonly, PDA is a contributor for newborn hypotension. Right, next slide, please. Next slide. Yes. Now, again, it's important to recognize there are differences between shock and hypotension. Shock is circulatory impairment of a newborn leading to a state of impaired oxygen delivery to tissues. We should not rely just on the blood pressure to determine whether a baby is in shock or not. Next slide. Right. Now we are coming to the question, when to treat low blood pressure in a newborn. So this has been a controversial area because to treat hypertension, we have to use inotropes, and nobody knows about the short-term and long-term adverse effects of inotropes properly. Especially in extremely preterm babies, there have been concerns related to increase in the prevalence of intraventricular hemorrhage, and also whether there could be adverse long-term outcome related to death and neurodisability in this group of vulnerable babies. Next slide, please. Right. So therefore, important trials have been conducted to study this important phenomenon, hypertension, and the decision to treat. One such interesting trial is the HIP trial that you might encounter when you are reading about hypotension in babies, which has assessed the treatment of hypertension in preterm infants. Next slide, please. So there you can see that they have taken those with mean arterial blood pressure less than the gestation age at birth in weeks. They have measured it over 15-minute period, and they have randomized them into two groups where when the blood pressure starts dropping, they have started with a bolus of saline 10 ml per kg, and in the treatment group, they have started dopamine and gone up in the dopamine slowly, whereas in the placebo group, they have just given a placebo without starting dopamine. However, in both groups, they have gone for additional therapy if there were additional criteria, such as very low blood pressure, or capillary filling time more than 4 seconds, or lactates more than 4. Right, next slide, please. So when you see the results of it, you see that there is no significant difference in the survival in both these arms when you want to manage these babies conservatively versus just starting dopamine with a drop of a hat and going up in the dopamine. Next slide, please. When you look at the long-term parameters as well as acute problems, also you see that being conservative does not increase the mortality, does not change any ultrasound abnormality in the brain, especially IVH, periventricular leukomalacia, and also problems related to gut hypoperfusion such as necrotizing enterocolitis and bronchopulmonary dysplasia and things like that. Next slide, please. And when they have measured the changes in the blood pressure, you can see that those who are treated with dopamine has had acute and significant changes and fluctuations in the blood pressure, whereas those who are on placebo treatment, they have had a steady and a nice change in the blood pressure, which is what is recommended in the newborn, especially in the preterm baby. Next slide, please. So therefore, people have come to this concept of permissive hypotension. So those who are studying and working in neonatal units, we are very familiar with this word permissive. We used to talk about permissive hypercapnia. Likewise, now we are talking about permissive hypotension as well. So now the understanding is that in babies, in newborns, a transient drop in the blood pressure is very common, and the mean arterial blood pressure could easily fall below the gestation, or what we already known as the definition for hypotension. But we also know that this mild amount of reduction in the blood pressure, which is transient, is not associated with poor outcome. Therefore, if your baby is stable and having moderate hypotension, remember moderate hypotension means your baby's blood pressure is just less than 5 below that corrected gestation age. If you take a 30-weeker, it's still between 25 to 30, and this baby is stable. So that baby is known as to be having permissive hypotension. So treatment with an inotrope is not recommended in this baby. Next slide, please. Right. So then the question comes, if you say, okay, the stable baby with moderate hypotension does not need treatment, who are the babies that I have to treat? So the first sign, clinically unstable babies. Now I'm coming to perfusion. Those who are having signs of poor perfusion. Those babies need treatment with inotrope. So what are the signs of perfusion? Now we are going to look at tachycardia. So in a term baby, above 160, in a preterm baby, above 180. I mean, not just looking at the number, look at the trend. A baby whom you have seen in the morning with a nice heart rate of 140, now you step into the NICU for the night shift. Now you see all of a sudden gone up to 170. So you don't have to wait until the baby reaches 180. You know something is going on. That's why this baby is becoming tachycardic. You look at the nurse's chart, you see the progressive rise in the heart rate. So you expect a problem with the perfusion. And check the capillary filling time centrally, and if it is prolonged more than 3 seconds, then you know the perfusion is not good in this baby. Skin color is very important, and our eyes must be trained to recognize that baby who deteriorates very quickly and changes the skin color, mottling and all that. So you have to recognize that baby as having signs of poor perfusion. Reduced urine output is also an important marker, and also you can collect other data regarding the lab markers, especially your blood gas with acidosis less than 7.25, base deficit more than -5, and lactate something about 3. You would consider as the baby is having poor perfusion. So that is one clinical criteria to help you to decide whether this baby needs treatment for hypotension. Then the next indication for you to treat a baby's low blood pressure will be a baby with severe hypotension. So that is for a 30-weeker, if the baby's blood pressure is below 25, then you know it's a severe hypotension. So that's an indication to treat this baby with inotropes. Next slide, please. So before you start writing your inotrope, you have to do certain assessment of your baby. Make sure you are doing invasive blood pressure measurements. Well, it might not be possible in all scenarios, but invasive blood pressure measurements are the preferred one. We all have to get used to doing this in our setup as well. It's not very difficult. And the blood pressure measurement apparatuses are also available in most of the hospitals. It's just that we are not using it. You have to go and assess for signs of poor perfusion that we have already discussed before, assess the fluid status of the baby, and also look into the causes. The clues would be you do a cardiac examination. Do you hear a murmur, bounding pulses? Do you see a significant pulse pressure, which could point towards a PDA? You examine the abdomen. Are there signs of necrotizing enterocolitis? You can quickly do a bedside ultrasound scan. That is a basic competency in anybody working in the newborn unit, to use that probe and to see whether there is a significant intraventricular hemorrhage. Do you think your baby is having sepsis? Was this baby on a line for a long time, or were there risk factors for sepsis at birth? Is this baby hypothermic? And does this baby look anemia? Those may be important clues in your initial assessment, because these conditions need treatment hand in hand with your management of hypotension. Next slide, please. Yeah. So if you have an echo, if you have that facility, it will be very handy, because you can get correct information regarding the exact cause. You can know whether there is a myocardial dysfunction, because you can see the contractility. Is there a congenital heart disease? Is there a PDA? You can get an idea about the vasomotor tone, and also an idea about the fluid overload. Next slide, please. But just because you don't have the echo, which is the fate for most of us in our country, don't be disheartened. Again, you can get some idea regarding the pathophysiology in your patient, depending on your blood pressure. So most of the time what we see is, when we do the ward round in the morning, we ask the blood pressure. We are always told that single number, the mean blood pressure only. But remember, these babies also do have a systolic blood pressure as well as a diastolic blood pressure. And they also have a pulse pressure as well. So we have to now work with these numbers to realize what is actually going on with these newborns. Don't just stick to that mean blood pressure value only. So if you see your systolic blood pressure is low with a normal pulse pressure, then it's a systolic dysfunction. So there's a problem with the cardiac contractility. If you see your diastolic blood pressure is low with a wide pulse pressure, well, this is a very common scenario that we see in babies with PDA. In adult medicine, we have seen this phenomenon occurring in patients with aortic regurgitation. Maybe we don't see it in newborns, but the same principle applies there. So you see, if you see this pattern where there's a low diastolic blood pressure with a wide pulse pressure, then it's due to either a PDA in the neonate or a reduction in the peripheral vascular resistance, which is due to sepsis. So there you go. Even you don't have an echo assessment, now you can get an idea about the two main pathologies that leads to hypotension in the newborn. So having a certain idea about the pathology is extremely important for you, because you have to choose the correct inotrope depending on the problem which is there in your baby. Next slide. So now you are going to ask me, okay, how can I know what are the normal values for systolic blood pressure in these babies? Because they all depend on the gestation, isn't it? So this chart I'm putting up here, not for you to memorize, but if you carefully look at this chart, you can roughly see that your systolic blood pressure, this is third percentile. So you know the lowest acceptable value is generally 10 above your gestation, isn't it? So your diastolic is generally 10 below your gestation. So this is common in other, this is fairly okay estimation in most of the gestation. So if you have this chart, please refer to it. If you don't have that this chart, that might be a tip for you to identify whether your patient is having low systolic blood pressure or a low diastolic blood pressure. So next time when you walk into the NICU, just try to do that assessment of systolic, diastolic, blood pressures and looking at the pulse pressure rather than just concentrating on the single number of mean arterial blood pressure. Next slide, please. Right. Now we know what hypotension is. Now we know who are the babies we need to treat. Now we know how to assess these babies. And now we know what could be the problems behind this hypotension as well. Now we are going to look at the management, the principles of management of a baby who is having low blood pressure or hypertension. So there are three main elements. One is your fluid management, one is your inotropes, and then obviously you have to treat the cause, otherwise you are not going to win this battle. Next slide. Right, talking about fluid boluses. Now we are very fond of giving fluid boluses for newborns. That is our reflex. Whenever you see a baby with low blood pressure, that we do as a reflex, give a fluid bolus. Again, make sure you do a proper assessment and determine whether this baby needs treatment. If you think this baby needs treatment, according to the previously discussed principles, only you are going to treat this baby. Right. So, judicious use of fluid boluses is extremely important because if you try to overload this baby, remember most of the babies are not hypovolemic. They are not losing blood. They are not losing volume. Most of the time, it's reduction in the peripheral vascular resistance or reduction in the contractility. So if you just use fluids just because you're fond of using it and just because you're used to use fluid boluses, you're going to make the baby volume overloaded. This is not good for a heart which has already failed. Just imagine the immature myocardium which is having a poor contractility in an extreme preterm baby, or a term baby who has had hypoxic ischemic encephalopathy, now due to hypoxia having poor contractility of the heart. If you do a volume overload, that heart is going to fail. And also in preterm babies, you put them at increased risk of developing pulmonary hemorrhage, intraventricular hemorrhage, opening of a PDA, and long-term increased chance of developing chronic lung disease. Therefore, if you have to use fluid boluses, you have to use it, but be very careful. Maximum 2 boluses you can use. After that, you always have to consider inotropes. Next slide, please. Right. So you can actually make the use of ultrasound scan to make an assessment regarding the fluid status of the baby. Now you see, this is the inferior vena cava in the ultrasound. This is a very easy image or view that you can obtain with your ultrasound. You can actually learn it on your own, because most of our registrars know how to do the ultrasound scan of the abdomen as a part of the assessment of dengue hemorrhagic fever. So just learn this as well, how to do the assessment of the fluid status. Now you see this is a fairly distended IVC, so meaning this baby is having a good volume status. So just giving fluid boluses is not going to be helpful in this situation. Right. Next slide, please. Right. So now we have discussed about the first arm, which is the fluid. And now we are going to talk about inotropes and vasopressors. Yeah. Now, inotropes means those who are increasing the contractility of the heart, whereas the vasopressors are increasing the peripheral vascular resistance. Now we need to know what these medicines are doing to your patient. Otherwise, you will be just haphazardly using these medications and you are not getting what you want to obtain, as well as you are putting these babies at risk of developing complications as well. So now our well-known and favorite and mostly used inotrope is dopamine. It is well accepted to be used in newborns, including extreme preterm babies, and most of the guidelines for treatment of hypotension would start their treatment with dopamine. Remember, dopamine has two actions, inotropic actions at moderately low levels from 5 to 15, but if you use very high doses above 15, it has got the vasoconstrictive effect. So that's important to remember. Epinephrine. It's a potent inotrope, increasing the contractility of the heart. In very high doses, it also causes vasoconstriction. Next click, please. Yeah. So you have NORAD. It's a pure vasopressor. It does not increase your myocardial contractility. It would just cause vasoconstriction. So it will affect your peripheral arterial vascular resistance. Okay. Right. Next one. Yeah, then you have dobutamine. So in newborns, remember, dobutamine gives rise to a highly variable response. In some babies, it increases the blood pressure. In some babies, it reduces. It will be difficult for you to guess. It is generally an inotrope, which increases the contractility of the heart. However, it is well known to increase the heart rate of the baby as well. Then we have the milrinone, which is an inotrope as well as vasodilator. Its use is mainly in babies with persistent pulmonary hypertension of the newborn. And then we also have this new thing, vasopressin, which is a pure vasoconstrictor. So knowing the mechanism of your inotrope is extremely important, because if you are dealing with a baby with poor cardiac contractility, you need to use an inotrope and not a vasopressor. Because if you go and use a vasopressor and increase the vascular resistance of a baby whose myocardium is not working properly, then you put that baby at risk, because your myocardium is not working, but you have now increased the resistance of the blood vessels. So your baby is going to deteriorate. But in a baby who is having reduced peripheral vascular resistance, example, severe sepsis, septic shock, then you have to get the use of your vasopressors very early. So that's why it's important to know the mechanism which has led to the low blood pressure in baby, as well as the mechanism the medications are going to work in your baby. Next slide. Okay, hydrocortisone has also been introduced into algorithms of treating newborn hypertension quite recently. Now, the idea is that we think the sick preterm infants, they have lower blood cortisol levels, and they also have a limited ability to increase the cortisol production when they face stressful situations. Therefore, hydrocortisone at a dose of 2 mg per kg given 6 hourly has been found to be very useful in managing hypertension in babies. We know that it's going to increase the responsiveness to circulating catecholamines, thereby it's going to increase our myocardial contractility as well as vascular tone. Next slide. Right. Now coming into management algorithms. Now when it comes to algorithms, we can see a clear difference between two groups of babies. First, we are going to look at the extreme preterm baby in their first 3 days of life, or first 72 days, 2 hours of life. And then we have those who are more than 28 weeks, including the term babies and also ex-preterm babies who are older than 72 hours of age. This demarcation is because of the extreme fragile nature of the extreme preterm baby in the first 3 days of life. We all know that these babies are the most vulnerable babies, the extreme preterm baby, and also their vulnerability is highest during their first 3 days of life. That is the duration where they lack the cerebral autoregulation, and that 72 hours is where you have the maximum risk of developing a significant IVH. You don't commonly see babies developing intraventricular hemorrhages after that. And also, these babies are very sensitive for vasoconstriction. Even if you use the slightest dose of your inotrope or vasopressor, the blood pressure is going to fluctuate massively. And also remember, in these babies, absolute hypovolemia is very uncommon. It's commonly the myocardial contractility or reduction in the peripheral vascular resistance. When you take the other category of babies who are stronger babies, actually, including the terms, so they have a reduction in the risk of intraventricular hemorrhage. That's why we are a little bit relaxed about these babies. And they can develop hypertension due to a variety of causes, including hypovolemia, poor contractility, PPHN, vasodilation, and so on. So there are these two categories you have to make sure that you remember. Next slide, please. Okay, so I'm now going to concentrate on the more fragile group, that is the less than 28 weeker in their first 72 hours of life. Next slide. Okay. So you start off with our favorite 10 ml per kg of saline over 30 minutes. Remember, it's never a rapid flush because it's going to increase your IVH. And then you are going to, if still there is poor response, you are going to start off with dopamine. Now remember, you should not quickly increase dopamine in this group of fragile babies. It should be incremented only by 3 to 5. You can't be starting off with 15 and or start with 5 and all of a sudden go up to 20. That's not recommended because of the reasons that I have discussed before. So you slowly go up and then you keep on assessing the fluid status as well as the other parameters. Only if necessary, you are going to repeat the second bolus. So you have been very careful here. And there's a place to consider hydrocortisone very early in these babies because we know that their response to stress response, the cortisol response to stress is not very good. And also when you are giving hydrocortisone, it takes some time for the hydrocortisone to act. So therefore, you can consider giving hydrocortisone early in these babies. Next slide. Then you are going to decide to which category your baby belongs to. If you think it's due to low contractility, which is commonly the cause in extreme preterm babies soon after birth, reduced contractility, then you use inotropes and avoid using vasopressors. So you can either use so you can, after exhausting your dopamine to 10 to 15, you can start a dobutamine or low dose adrenaline. And if you are already on a higher dose of dopamine, of dopamine, example more than 15, you consider going back and reducing your dopamine. Remember, all these babies are now on dopamine, okay? And your clinical judgment is that there is a reduction in the vascular tone. Example, septic baby. So then you have to use vasopressors. So there you have room to increase your dopamine further, maybe up to 20. And then consider starting adrenaline and go up very slowly. You can consider hydrocortisone also. In those babies, when there's a significant PDA, rather than treating with a second inotrope who are already on dopamine, it's always advisable to use other measures now and to control your PDA. One good thing is to change your ventilator settings now to increase the PEEP to 6 to 7, sometimes 8. And also try and close your PDA and consider stopping hydrocortisone. Next slide. Moving on to the other group now, this the more stronger baby. Yeah, next slide. Yeah, so there you go by the pathophysiology from the very beginning. So we know the common problems they are going to get. They commonly get sepsis or necrotizing enterocolitis. We know the problem there, mainly vasodilation. So you need to use vasopressors very early. So these babies, you can give 10 to 20 milliliters per kg of saline bolus, and you go for a dopamine, high dose more than 10. And if you want further support, then you go for something like NORAD or vasopressin, preferably NORAD rather than vasopressin, because now you want more tone in the blood vessels. Next slide. If your baby had a blood loss, example, term baby born after placental abruption. So consider giving red cell transfusion very early, rather than going up and up in your inotropes. So you can go in your fluid, including the blood, up to 30 mils per kg. Right. In the next scenario, you have the baby with hypoxic ischemic encephalopathy. You know the problem is with poor contractility. So again, here it's very important. I mean, we have seen babies who has been treated with multiple doses of saline just to get the blood pressure, and that has put them at risk. And those babies have gone and developed heart failure on top of all the other problems that they have. So maybe just one bolus, repeat only if necessary after proper and careful assessment. And these babies, make sure you need something to improve the cardiac contractility rather than giving a vasopressor. So you can consider hydrocortisone also very early in these babies. Next slide, please. Yeah, this is not a very common scenario. Those who are with myocardial hypertrophy, I'm just mentioning it for completion. We always have to discuss with cardiology to choose the proper inotrope in these scenarios. Always remember, if you are not successful when you are going up in the ladder in the algorithm, always contact the cardiology team. Always get a proper echocardiogram and see whether there is a congenital heart disease which is hiding there, and which is that's why this baby might not be responding to any of your treatment. Next slide. Right. So in the case of no response, just see, is there a technical problem in the delivery of your medication? Is there an administration error? Have I prescribed it in the proper manner? Because prescription of inotropes could be very tricky if you are very, very busy or feeling dizzy after a very long night shift. You might have done an error in writing it. We all do errors. So just double check, get somebody to check your prescription. Sometimes it's due to high mean airway pressure. This is a very common scenario in babies who are on high frequency. So in high frequency mode, actually the babies are getting fairly a higher amount of mean airway pressure. So what happens is when your intrathoracic pressure is high, it impedes the vascular return to the heart. And that could be the reason why your baby is not responding to your inotropes and the management. So make sure, especially if your baby is on high frequency oscillator, clinically you cannot determine whether you are giving adequate amount of pressures or you are overventilating the baby. So you always have to do a chest X-ray and see whether the lungs are hyperexpanded, meaning you can see more than 9 ribs posteriorly in the X-ray. That will definitely show you whether you are giving more pressure to this baby. Look whether there is a pneumothorax. Look whether there's a pericardial tamponade. There could be a hidden blood loss, especially subgaleal hemorrhage in a term baby whom you are treating for hypoxic ischemic encephalopathy, who was delivered following a vacuum delivery. Is it a drug side effect? Or is it just because you did not choose the medication appropriately? So think before you just keep on increasing your inotrope and keep on adding one top of the other. Next slide. Next slide. Yeah. So with that, we have come to the end of our presentation. I'm sorry there had been a couple of interruptions to the presentation, probably because of the poor internet connection. I'm really sorry about that. So if I'm to summarize, so we discussed what hypotension is And we discussed that intervention for hypertension is indicated in babies who are either having poor perfusion or severe hypertension. And we also learned that there could be a lot of causes, but generally in the extreme preterm baby initial period, it's due to poor myocardial contractility. Occasionally, it could be due to reduced vascular tone. And in the more mature baby, it could be due to a variety of causes, including hypovolemia. And we also learned about the commonly used inotropes, and we now understand that we have to use the inotropes very carefully according to the pathophysiology, underlying pathophysiology leading to hypotension of this baby. Right. Thank you.